So one of the things I want to touch on is, let's say, prior authorization. This has become a big problem for a lot of folks who are, especially in an inpatient environment. Maybe they're transitioning from an ER into an inpatient stay, and there's been work done by an ER doctor, which is essentially the medical necessity notes that are being used to get the prior authorization for inpatient. And they're not getting it. The Medicare Advantage plans are much more strict about this. They're looking at the medical necessity and the records at a more granular level. And what that means is the person who is ultimately going to need that talking to is the physician. And everyone knows that physicians, they walk around, they've got a lot more credentials, they've got a lot of experience, they're smart people. How do you go and have the conversation with the physician about whether it's how they need to do things differently? And maybe it's not because they really have to, it's because the insurance companies are essentially cornering them into having to do this. And so they're going to have to change behavior, at least for a subset of their patients. What are tactics you've seen that work for helping change behavior of one of the folks in the sort of wearing the doctor title? What works in those situations?
Well, the first thing that comes to mind for everyone, I'm sure, is just show them where it's hitting them in the pocket, right? Tell them what it's costing them. In revenue, they could have made another $100,000 if they had done A, B, or C. It's not always true, the economics of it. In fact, I just read a recent thing where that is not what always drives physicians. They do have a little bit more, they're in this field for a reason. It's about the people, the patient. I've had physicians walk out on a presentation I've done before where I'm showing them clearly they have one physician's losing $60,000 a month simply because they are not clicking this one field in the EMR system, while all their peers are. Peer pressure does work. You kind of show a comparative between similar specialties, right? You show Dr. A, B, and C is doing this for the exact same procedure. And they can kind of look and go, wow, okay, so what am I not doing that they are? So peer pressure, showing the loss of money. Again, if that doesn't work, you ask the why. Why is it that when we say you need to get your notes closed, or why is it when you come out of surgery, knowing we prior authed for surgical procedure A, but you had to go, when you went in, you realized, oh, I'm going to have to do a little more. This is more extensive than I expected. So you do that. When you come out, you've heard them yelling over at the billing department, oh my gosh, we didn't get a prior auth for that other thing you had to do. We had no way to know. So it's that communication again between the facility or the hospital where you perform the surgery. How do we get everyone on the same page so that the paper trail follows to the right department, gets back to the prior auth lady that says, okay, surgery's done, his notes are done. The hospital billing people are over here going, oh my gosh, we need that other prior auth also. So it's a collaboration. The doctor needs to really sit down and hear what you have to say. Now, again, these are surgeons. They're ready to move on to their next surgery. They really don't want to hear about the paperwork. But I think if you can identify, let's say, a pattern, I love enforcing the concept of pattern identification. If you know that this surgeon that does 6 of these a week, and those are the ones that oftentimes 4 out of 6, once he gets in there, he has to do more. That's when you can have that conversation. So you're not coming at him from just a broad discussion of, my gosh, you're doing stuff that we haven't prior auth. You say specifically, you do these 4 out of 6 times, we have to get prior auth redone. That's how you can kind of get them on board and understand without overwhelming.